Good morning, good afternoon, and welcome. Thank you so much for joining Sodexo today for our webinar on the power of standardizing cleaning and disinfection protocols across healthcare systems. I'm Lisa Zierten. I'm the Vice President of Healthcare Marketing for Sodexo, responsible for our environmental services portfolio. For those of you who may be unfamiliar with Sodexo, we are part of a global Fortune 500 company with a presence in over 50 countries. Sodexo is a leader in providing non-clinical support services to healthcare systems, including environmental infection prevention and clinical nutrition. We serve more than 700 hospital customers across the 50 United States, and our mission is to support you, our healthcare customers, in your goals of delivering best-in-class care. And we do this by providing support that improves overall quality and efficiency and ultimately contributes to improved health outcomes. Joining me today to lead the rest of the webinar will be Brooke Hossfeld, Sodexo's infection prevention specialist. So a little bit about Brooke. She brings 15 years of cumulative knowledge and experience in healthcare and infection prevention. And before joining Sodexo, Brooke was at Weiss Memorial Hospital in the Chicago area, where she served as infection control practitioner and emergency preparedness coordinator. Her prior experience to that included various roles in infection control and prevention, including positions with the Department of Homeland Security in their Office of Emergency Preparedness, as well as positions in clinical laboratory education and medical laboratory sciences. Brooke holds a Bachelor of Science degree in medical technology from Michigan State University, as well as a Master's of Public Health in epidemiology with a focus on infectious diseases from Tulane University. She is certified in infection control by the Certification Board of Infection Control and Epidemiology Incorporated, and is a licensed medical technologist with the American Society for Clinical Pathology. Additionally, Brooke is an active member in multiple organizations, including APIC, the Association of Professionals for Infection Control and Epidemiology, both at the local and national level. So before I turn it over to Brooke, we had a few housekeeping details that I'd like to go over. So first, if you have questions, please put them in the Q&A feed, and we'll answer them during the Q&A session at the end. Secondly, we have a few polling questions throughout the presentation, and we would love to hear from you and encourage you to participate in those. And last but not least, our friends at Leapfrog will be following up after the webinar with a thank you email that has additional information, a copy of the presentation, and a link to the recording for it. And with that, I'm going to turn it over to Brooke. Thank you.
Thank you, Lisa, and thank you to all of you for joining us today for this webinar, and an additional thank you to Leapfrog for hosting this event. So this is the agenda for today's presentation and the topics that we will be covering. So there are a lot of changes occurring in healthcare that can affect patient health and safety, with healthcare-associated infections having a significant impact. The population of patients requiring care is increasing. The movement of patients from inpatient to outpatient facilities can impact care, quality, and service delivery. The movement of these patients can also lead to a loss of control for patient safety and quality of treatment from inpatient to outpatient. We will see an increase in acuity and volume of conditions, which may impact length of stay and may also impact the diagnosis and treatment of HAI. So let's look at this a little closer. So what's happening with an aging population? So many are dealing with one or more chronic conditions that will require ongoing care, medication, and specialized treatments, all contributing to already rising healthcare costs. The healthcare industry is already feeling the strain of dealing with the baby boomer generation, and it will only increase as more Americans retire from the workforce and move into alternative care living situations. So now I'm going to be opening it up for the first poll question. If you could please answer.
We do have results. It looks like the majority of folks, 56% said 42 million, with a close second at 37.
Wonderful. Well, thank you all for responding. So the number is actually C, so 37 million adults. Why? Nope. Not sure. Oh, there we go. Okay. So as I said, it's 37 million people. So as stated before, the aging population with a greater number of elderly and more chronic conditions will continue to grow into the next decade. Patients are entering healthcare facilities with community-acquired infections, equating to longer lengths of stay and creates risk for non-infected patients contracting HAIs, such as C. diff. There is also an overall higher risk of morbidity and mortality within these populations. Adding to that risk is the nursing shortage and widening labor gap. Projection into the future predicts a significant need for nurses. Many of these nurses are boomers and will also be retiring. These are preceptors, mentors, and nurse educators. Their loss will have a substantial impact on the current nurses and the training of new nurses. Cognitive overload, too many patients, being tasked with non-clinical work, all can lead to lapses in areas like hand hygiene, patient equipment cleaning, correct use of PPE, infection prevention bundles for indwelling devices, patient bathing, and other items related to care and treatment. The increase of patients seen in skilled nursing facilities, long-term acute care, and senior facilities will lead to the same labor challenges, as nurse-to-patient ratios are much higher in these outpatient sites and can lead to lapses in care. And there was so much scrambling that was happening during COVID and all of the following waves that many aspects of patient care fell to the wayside, leading to increases in HAIs that have been seen in hospitals across the country. So, how does this affect hospital financials? In addition to labor issues, reimbursements are lower and not keeping up with hospital operating costs, with 2022 Medicare payments at a record low, which is 82 cents on each dollar spent on care. CMS is proposing new standards and stricter guidelines for hospital-acquired conditions, or HAC penalties, that will make it harder for hospitals to perform at optimum levels. All of this can lead to more HAIs, more readmissions due to HAIs, less reimbursements from CMS, and less operational money for all hospitals, all adding additional stress to an already challenged healthcare market. And now we are going to move on to our next poll question of what is the average cost of an inpatient C. diff HAI?
All right, Brooke, it looks like we have some answers here. Again, the majority are pegging the cost at 15,000 with 17,000 as a close second there. So smart people in the room here.
Yes. Thank you all again for your responses. And the correct answer for this, see, it's taken a little bit of a lapse to go back after the poll. So the correct answer was D, so 17,000. So not to put too much emphasis on HAIs, but they cost money. Patients coming into acute care facilities from outpatient care may be colonized or have previous history with pathogen-causing HAIs. Delay in identification and isolation can potentially lead to transmission to other patients and staff. And as I just stated, HAIs, they're not cheap, each leading to longer lengths of stay, increased cost for treatment, labor, product usage. And once a patient has had an HAI, particularly MRSA or C. diff, they are likely to get it again, leading to a readmission and all the excess costs related to that. So we talked about trends, patients, labor, costs. Now let's touch on the shift to outpatient care. This care setting study, conducted by Sodexo, shows projected growth information from acute to non-acute centers. Certain outpatient facilities, such as skilled nursing facilities, long-term acute care, and nursing homes, were not included. Care is shifting away from hospital inpatient towards outpatient settings, given lower cost of care, value-based care pressures, and patient preference for non-acute settings. Care is also shifting from emergency departments to primary care offices and primary care offices to urgent care centers, driven by patient preference and payer steerage, accelerated by limited emergency department access due to longer waits and labor shortages. Hospitals are not growing at the same rate as non-acute services. Many systems are dealing with mergers and acquisitions, creating a dog-eat-dog world for choice of site for service. Procedures are moving away from inpatient towards ambulatory surgical centers, driven by cost savings, technology improvements, and patient preference. However, this shift from hospitals is counteracted by simultaneous trends towards telehealth and urgent care clinics. Consolidation of care has some areas moving directly from inpatient to outpatient, such as orthopedics or OBGYN. So what does this mean for HAIs? Well, the expansion of patients that are seen in SNFs, LTACs, and nursing homes leads to less control for patient safety and infection prevention surveillance. Seniors have the greatest risk of transmission out of all outpatient areas. Extrapolations based on estimates from older CDC data suggest that infections could result in as many as 380,000 deaths among outpatient senior residents every year. 50 to 70% of all C. diff HAIs are emerging in seniors' facilities. Between 35 and 51% of residents are colonized with MDROs. These pathogens can be spread to other residents and staff via contaminated hands and surfaces. A study by Alder Milton et al. That was published in JAMA in January 2021 surveyed 500 skilled nursing facilities that collected detailed data on information sharing that supports care transition from each of the two hospitals from which they received the largest volume of patient referrals. The survey administration occurred between January 2019 and March 2020. Of the points measured in the survey, receipt of hospital information was delayed sometimes or often, arriving after the patient at 33.8% and 16.4% respectively. This led to delays in care, room placement, and identification of patients with an active infection or history of infection from a multi-drug resistant organism. So what does this mean for outpatient senior facilities? CMS is changing regulations around infection prevention and have now mandated a full-time infection prevention professional be on staff at senior facilities. All sites must have infection prevention standards and training in place. Monitoring of occurrences of HAIs among senior facilities can provide valuable information about quality and timeliness of care. A study from Modi et al., published in JAMA in January of 2018, found that nursing facilities encounter many challenges in effectively implementing and maintaining infection prevention programs. First, both patients receiving post-acute care and long-term residents frequently visited common areas, including dining rooms, rehabilitation areas, and family visitation rooms. increasing the risk of pathogen transmission. Second, nursing facilities lack in-house diagnostic testing and rely on off-site physicians, leading to delays in the evaluation and management of individuals with acute infections. Third, the post-acute care population has inherently more active medical problems with more devices, wounds, recurrent hospital stays, and high antibiotic use compared with those long-term care residents. Most important, nursing facilities lack adequate resources to support the increasingly complicated infection prevention mandates, such as infection surveillance, staff education, and implementation of antimicrobial stewardship programs. So now on to our third poll question. So are you currently working in a health system with integrated facilities, such as a skilled nursing facility, a long-term acute care facility, or seniors facilities?
Hey, Brooke, it looks like a quarter of our respondents had answered yes to that and 75% no.
Oh, okay. Very interesting results. Thank you for sharing. A little bit of a lag. There we go. So, why is environmental infection prevention so important for outpatient senior facilities? We've already discussed how the movement of patients from inpatient to outpatient care comes with many challenges. Outpatient clinics such as hemodialysis, wound centers, and infusion centers are seeing high numbers of immunocompromised patients. Senior facilities have high traffic areas such as common rooms, dining halls, and activity rooms that are used by staff, residents, and guests. Outpatient sites need constant cleaning and disinfection with products that are known for breaking down biofilm. By keeping surfaces cleaner for longer, patients and staff have a lower risk of acquiring infections in these high traffic areas. So let's tie up all of these themes. Increases in patients and decreases in labor, excess costs of burden, inconsistency of care, and high reimbursements. Addressing these issues are vital for patient safety and care. And now we're going to move into a little bit more about standardization of this care. And we're going to move into our final poll question. So what is the average number of ambulatory or non-acute sites per integrated delivery network?
All right, Brooke, we have some responses here. It looks like the majority of folks said 116, with 153 a close second.
Wonderful. Well, thank you again for your responses. So the correct answer for this one is C, so 153. And this information really came as a surprise to us as well. And this information is based on analysis of information from Definitive Healthcare. And significant numbers of outpatient sites introduces challenges to standardizing care and support services. Here is an example of a 26 hospital system spread across multiple states with 5 different EVS providers, 5 different sets of standard operating procedures, chemicals used, and staff training. The inconsistencies between cleaning and disinfecting products and processes across these hospitals open risk for regulatory issues. You have to stop and ask yourself, how are things being cleaned? What chemicals are being used? How are staff trained on proper usage? Are these chemicals even effective against all pathogens of concern, such as C. diff, VRE, Candida auris, or CRE? Infection prevention typically covers the hospital. Does your IP know how the imaging center attached to your hospital is cleaned? The ASC across the street? Do you know how all these different areas are cleaned? Do you know who manages all of the different outbuildings associated with your facility? By standardizing your procedures of cleaning and disinfecting, chemical usage, training, and management, you'd be able to answer yes to all of these questions. And the number of facilities can drive the number of vendors. This is quite typical. One of our clients, a children's hospital, has over 60 ambulatory sites that are associated with that main facility. Healthcare systems that were working towards standardization of care experienced slower than usual conversions due to COVID. So your non-clinical areas such as patient registration, electronic medical records, and the laboratory have all been moved to a standardized method. A shift is moving towards standardizing certain non-clinical areas. Why not move towards standardization of all of these areas? A need is there, and the gap in non-standardization will become more apparent as the shift from inpatient to outpatient increases. As mentioned before, healthcare systems are moving towards consolidating services around fewer vendors across the system to streamline vendor management and capture economies of scale. We've just finished a needs-based survey of our customers, and it is a follow-up study from a previous survey done in 2022. We received a significant increase in replies for the need of increased standardization and services and management. Standardization of services also reduces cost and increases predictability of results. As purchasing decisions across hospitals are being standardized, market participants expect standardization across non-acute facilities to follow. During and after COVID, we've been dealing with, and then the aftermath of labor and supply chain issues. Now we're trying to get back to those pre-pandemic levels of standardized care. So SAB et al. Conducted a survey of cleaning procedures across senior facilities and found that the greatest variation was in time to clean, anywhere from 10 to 30 minutes, as well as training and continuing education. However, time spent cleaning by a contracted company brought in for environmental services in this study was associated with improved cleaning effectiveness. The CDC conducted a survey of ambulatory surgical centers and found several lapses in infection prevention standards, such as wearing PPE and appropriately cleaning high-touch surfaces. From the previous slides, we already know that standardizing this process would lead to better survey results and improve patient care. So, why standardize environmental services? The same bundle of products and the same standard operating procedures in place across all areas of management have been proven to give reliable and repeatable results. Identical training of staff with continuous quality audits and compliance check, regardless of facility type, can lead to improved staff satisfaction and positive outcomes. Management across the continuum of care. There's no questions regarding what chemicals get used where, and elimination of those mystery bottles of unlabeled chemicals that inspectors always seem to find during surveys. Choosing products that are safe to use and have easy to understand utilizations can potentially improve area turnover times, decrease risks of transmission of pathogens, and show repeatable results with increased patient safety and satisfaction. Throughout the years, Sodexo has gathered HAI data for environmental HAIs, such as MRSA and C. diff. Sodexo's Standardized EVS is our Protecta program. It is a bundle of chemical disinfectant, sporicidal, and single-use disposable wipes and mop heads. Recently, we've conducted a case study of systems where we've standardized EVS with Protecta and compared it to sites where Sodexo provides EVS services but uses the client's chosen chemicals, and with sites that do not have Sodexo providing EVS services. The sites that are using Sodexo's Standardized Protecta program have stabilized cases of MRSA at lower levels than those sites without standardized EVS. Now, the MRSA results cannot be completely attributed to standardized EVS. And this is just based on the fact that MRSA HAIs are diagnosed and reported as bloodstream infections. However, with Protecta, we're trying to decrease environmental transmission. So breaking through biofilm and providing clean surfaces in patient care areas, we can help reduce the risk of a patient contracting MRSA from a contaminated surface. And you will notice that Sodexo standardized EVS results for MRSA increased after COVID, similar to what all hospitals across the country experienced during that time frame. This C. diff comparison is looking at the same cohorts of hospitals using Protecta versus those using Sodexo for EVS and non-Sodexo EVS providers. The results for C. diff are much different than those for MRSA, as continuous cleaning of high-touch surfaces has been proven to reduce infections. Sites with Sodexo providing EVS services, standardized or not, had lower C. diff infections than non-Sodexo sites. During COVID, there was an increased focus on disinfection and hand hygiene, and this was thought to keep C. diff at lower levels than other HAIs. Now, medium-sized hospitals or medium-sized healthcare systems with 3 to 7 hospitals have an average of 3 to 4 associated off-site care buildings. Most systems had at least 2 different service providers for EVS. Because of this variation, we've had clients come to us with concerns about standardizing cleaning in outpatient sites. So evidence-based results show that Sodexo's approach to environmental services works at lowering HAIs in acute care settings. And we've been collecting this data from our client sites since 2016. And the payoff of standardized EVS for inpatient areas is in reduced infections and stabilization of trends. The MRSA COVID effect was once more seen at all sites utilizing Protecta for standardized EVS, and C. diff was held at a steady rate. We've been collecting data over several years and have seen the evidence that standardization of environmental infection prevention comes with the benefit of reduced HAIs from MRSA and C. diff. And we collect this data directly from CMS for analysis. So you could see our data goes to 2022. We're held at the same schedule as CMS for when they release new HAI data. So you've seen the evidence that standardized EVS services by a single provider provides reliable and repeatable results. Our Protecta program provides clients much more than just environmental infection prevention. EVS is truly the first line of defense for preventing HAIs, and standardizing this service will provide consistency across the continuum of care. Less variation in chemicals, one set of standard operating procedures, continuous compliance audits, improved training and staff satisfaction, measurable, and reportable KPIs all lead to the most important thing in healthcare, patient safety. So, to recap today's presentation, the landscape of healthcare is changing and will continue to change over the next few decades. Rising costs and labor challenges will contribute to the financial strain already experienced by healthcare systems. The transition of care from inpatient to outpatient facilities will make surveillance, identification, and treatment of HAIs more difficult. Hospitals have numerous off-site, high-traffic care areas that should be treated with the same level of cleaning and disinfection as inpatient care to prevent transmission of HAI-causing pathogens. And sites with standardized EVS programs in place will have the benefit of management across facilities, less variability, repeatable results, and once again, the most important point of all, improved patient safety. So thank you so much for listening. And now I would like to open it up for any questions you may have.
We did have a question, Brooke, from Kelsey, looking for the statistics that were mentioned during the slide, specifically on a number of infections found in nursing homes. So we do have the sources noted in the notes, but
Yes,
certainly, Kelsey, we can work through Leapfrog to do more specifics, or feel free. We have our contact information at the end of this slide presentation. You can reach out directly if you'd like. Happy to help. Brooke, we had a few questions, or a question, I should say, on the products that are used in the Protecta product bundle. If you would like to maybe address that with the group on the call.
Sure. So Protecta, which I had mentioned, is Sodexo's standardized environmental infection prevention program, is a combination of Oxivir as our chemical disinfectant and Defender, which is a non-bleach sporicidal for C. diff. And then our disposable items are single-use mops and single-use wipes. So it's a new mop and new wipes for every patient room, and it really reduces the risk of cross-contamination of dirty mops to a clean area or dirty rags to a clean area.
Brooke, we had another question from Steve. He's looking for a product that could be used on non-waterproof mattresses for cleaning and disinfection, I'm assuming.
So I would have to know where your mattresses were coming from. Typically in inpatient care and outpatient care, you see mattresses that have an impervious cover on them that you can zip and unzip. And we recommend using, the mixture of Oxivir and Defender on those mattresses after patient use to kind of, clean and disinfect and have a sporicide on them. But for items that are non-waterproof, I honestly, I would almost recommend that you get rid of those mattresses and move to mattresses that are waterproof for the simple reason of they're much harder to clean than something that has an impervious layer or cover on it. So that's an interesting question. I'm not exactly sure how to answer that, but my recommendation is to stop using those mattresses.
Yeah, and I think, Steve, we'd be happy again to do a little, research or on that, or get back to you with some other thoughts on that. So we had a question from Becca. Some hospitals are on a budget for certain departments. Would the disposable products be cost effective? Some other products are higher in cost.
So we do get this question a lot, and thank you so much for asking it. Sodexo has really started to move towards sustainability, particularly with water costs. So when you're using Oxivir and Defender, Oxivir is ready to use, and Defender is a tablet that is dissolved in water, and it's good for the shift of use, and then it will be discarded. It is safe to be put down the drain. It actually breaks down to water. And then to kind of offset the disposable costs is, we would be, if you're laundering on site or if you're getting your mops and wipes from off-site laundering facilities, you would be no longer paying that cost. You would no longer be paying for transport, for rental, for, cleaning, for, everything that's involved in laundering materials. So it's kind of a wash between moving to disposable and staying with launderable. And again, like I mentioned, it's really a lot better for cross-contamination. It really reduces risk of cross-contamination. It's, the staff really like them. It lessens the chance of staff harm because they're, pulling that bag of wet mop heads behind them as they're, going from room to room. So there's really a lot of other things that come into play with the movement of using disposable from launderable items.
And the other thing I might add on that one, Brooke, if you didn't mention it before, is just, are they really reusable? How many times are they reusable? There's a lot of studies out there that show a decreased efficacy on reusable microfiber after laundering, especially if they're being treated and dried in very, hot dryers. They are essentially a rosin-based product, and so you get kind of almost like a melting effect. So that can really impact the efficacy and the pickup of that textile. I think the other thing to keep in mind too, especially using textiles for wiping down more of the high-touch areas of rooms, is that after time these rags or these wipers can look a little a little bit kind of dirty and maybe not really as clean as you would hope. So there's a patient experience element to utilizing those as well. All right, so I think we answered any recommendations specifically on chemicals that can afford Defender or Oxivir.
Can you repeat that? I was kind of
Yeah,
hard to hear
so
that.
I just want to be cognizant of time here. Is there any recommendation for chemicals that can't afford Defender or Oxivir?
So I know, a lot of sites are, still using bleach. Bleach seems to be kind of the front line for C. diff prevention. However, bleach is, it's very damaging to surfaces. It can really start to, pit and eat at those surfaces over time. So, even if you were able to switch to one of your chemicals, if you were able to switch from bleach to Defender, you're not going to be replacing your, furniture and medical equipment as often as you would be when using bleach because you're damaging those surfaces. And, as infection preventionists, that once those areas become, pitted, cracked, chipped, whatever, you can't effectively clean those surfaces anymore. So, just trying to prolong the length of stay of your items, I believe would have cost savings over time. And then really any good chemical disinfectant, Oxivir is hydrogen based. So it's very effective. It's only a 1-minute contact time. So you also have to look at, the labor costs. How long is it taking for your rooms to be turned over after a patient is discharged to get it ready for the next patient? If you're able to switch one of your chemicals that has maybe, say, a 5 or a 10-minute contact time to a 1-minute contact time, you'll start to see cost savings in your labor as well. So, you might think they're more expensive. You might think a switch might not be optimal for you, but you have to look at the whole picture of where cost savings would be coming from by switching to different products.
All right, and thank you. Anonymous, here's a question about floor cleaning. I might be able to take this one. Brooke, do you want
Sure.
to add some color commentary? Do we recommend floor disinfection or just cleaning in acute care hospital settings? So standard patient rooms and hallways are not identified as an isolation room. Our standard protocol is not to disinfect floors unless they are, isolation or there's other precautions in that particular patient room. We do have a standard process and product set that is appropriate for the other kind of floor cleaning throughout the hospital. Let's see, is Oxivir rated to kill C. diff?
So it's not specifically rated for it, but it does show around a 2 to 3 log reduction in C. diff. So because it's not that 6 log reduction, they can't put it on their master label. But like I said, however, it does show efficacy. It is effective over, oh my gosh, I think 90 different bacteria and viruses that it is effective against, and it is also effective against Candida auris at 1 minute. So, it does, but it doesn't, it doesn't fit what the EPA says for having to put it on the master label, but there is evidence that it has some efficacy against C. diff.
Yeah, but that's why we back up with the Defender or the NADCC tabs.
Correct.
Angela had a question, which I think is a great one. So she asked around educational resources to help learn more about preventing cross-contamination while cleaning rooms, and then steps to prevent cross-contamination while in the room.
Sure. So, part of when Sodexo standardizes environmental services in a site is we kind of take control of a lot of the training of EVS staff. So EVS staff is trained on what Sodexo knows as the 7 steps for cleaning a room. So, high surfaces to low surfaces, the innermost corner to, the doorway to not, have cross-contamination. Our staff is trained on this. They're trained on infection prevention. And we would work with client sites, infection prevention teams to do any additional training that they might think the EVS staff needs to have. But this is staff training that we provide annually, and they have to take it annually as part of their, HR compliance checks for you for Joint Commission. And then we also have audits that we do. So we use a fluorescent gel that shines with the black light. So staff will go in and mark a room before a tech goes in to clean it, and then we'll recheck those areas afterwards to make sure that the mechanical cleaning process removed that gel from that surface. So, there's different, checks that we have. There's a lot of training that we have that our staff continues to go through. And like you said, one of those main things is cross-contamination. Why we use single-use items is to cut down on cross-contamination. But yes, we also train to clean the room in a way that will avoid cross-contamination.
All right. There's a question from Rebecca. Would Defender be able to pass in on their chemical testing department? So basically, I guess it's a question on, does it pass chemical testing in hospitals, Defender?
Yes, it does. Yeah,
Oh.
it's on the EPA list for C. diff. It's it's very safe. We have lots of clients that use it and love it, and have really had no issues with it. No, staff reactions, nothing of the sort. So it is a very safe chemical to use. Like I said, it breaks down essentially to water over 24 hours. So there's really no issues with it. It's very safe.
Okay. Question from Sherry. How do you come around IFUs that do not indicate the use of disinfectants that you have on site? They're trying to
So
limit the number of different disinfectants.
So when you're talking about IFUs, that usually more applies to medical equipment. So items like, IV pumps, wound vacs, things of that matter. EVS staff, we're strictly talking about rooms and the beds and the bedside tables. So we do have another service, and Lisa, if you want to jump in and talk about PEMS, but we do have a service that comes in to do the cleaning of my medical equipment, and we do follow whatever the manufacturer's IFU states for cleaning. So Lisa, if you want to add in.
Yeah, but I think in general, we would support, trying to at least, reduce variation, shall we say, in the number of disinfectants. So like purple tops, I think are used quite a bit in equipment cleaning. So, and I do understand sort of the challenges around that. I think, that may be a little bit more conversation required on that, just because of the significant, to your point, Sherry, variety in IFUs on that one. But we'll take down your name and I think try to get back to you with a little bit additional information. And then from Jennifer, we have a question around do we perform ATP testing and what product that we use?
So this is another question that comes up very often, and thank you so much for sharing. So we do not do ATP testing. We prefer blacklight testing, and there's a number of reasons that we prefer blacklight. For one, ATP, there's no real set standards from anyone. APIC, Joint Commission, SHEA, all of the different organizations out there don't really have a standard for what is considered clean. So when you're swabbing surfaces with ATP and you're getting a number, what are you comparing that to? Is it a number that you're making up? Is it a number that, the head of quality is making up? It's just a number. So it's very hard to determine if surfaces are clean just using ATP. You can have, variability in surface types. It picks up not just, ATP from bacteria, it picks up ATP from anything. So it's, there's quite a few false positives that come around with ATP testing. It doesn't really give you a good idea of, mechanical cleaning and disinfecting, which is why we prefer the black light, because we can see where that spot was marked, that all of that gel has been removed. So we know that that area has been wiped and clean. So, we do have opinions. If sites really want us to do ATP, we can still do it. But our method for quality compliance checks is blacklight testing.
All right. So a question, can you talk about terminal cleans in terms of oversight and standardization?
Sure. So terminal cleans, it's the same process that would be done during a daily clean, except wiping down everything in the room. So it's the same process of the innermost area to outermost area, high to low, moving furniture around, and then depending on what kind of room it is it a regular room? Is it an isolation room? If it's an isolation room, if it's C. diff, we're using Defender. I've forgot to mention before, but Defender can be used on the floor in patient rooms. So we will see client sites that use Defender on the floor for C. diff rooms. Others will just use a regular daily disinfectant. But it's still the same chemicals and processes that are used in daily cleaning for terminal cleaning. It's just terminal is terminal. You're cleaning everything. So it's the same products, it's the same processes. It's just is it daily or is it terminal cleaning?
Yeah, and just to add to that, Brooke, we have standard operating protocols and practices that we train our staff to. So we have one specifically for terminal cleans. We have for daily cleans. We have for OR terminal. So the content and the education is all standardized and sort of codified, so to speak, in terms of our written SOPs, which are the basis for which the basis on which we train our staff. So I think we had another. Let's see. I want to be cognizant of time here. I think Amy had a question. What mop works with for high areas with Oxivir wipes? I think we have a variety of tools, honestly, that we can use to make sure that we're getting at those high area higher areas of the rooms. So, we work with a variety of vendors to make sure our teams have the right, handles and tools to be able to do that. And then I think just, I want to see if there's any after this one. A couple of questions, Brooke, what the staff is, our EVS staff is responsible for, and I'm assuming this is a question about, do our staff get education on hand hygiene and PPE and gloves and gowns? I think the
Yes.
answer to the last one is yes. So, and then, our staff is basically at a high level, we're responsible for ensuring that the environment of care and surfaces in the hospital are kept clean and are disinfected to help, ultimately to reduce HAIs. All right. Well, we're getting close to the end. I don't know that we have any additional questions. We certainly can, help anybody on the line who'd be, interested in talking a little bit more. Here is our contact information, and obviously Brooke is our subject matter expert on this, but we'll work with Leapfrog to respond to any questions that we didn't sufficiently get to during the Q&A there. So I'll just wrap up real quickly. Thank you first to Leapfrog for helping us to reach you and talk to you today about standardizing cleaning and disinfection across the hospital system and external or outpatient sites of care. We really appreciate your joining us today. We know how busy you are, and we're very grateful that you chose to spend time with us today. So as mentioned before, I'll just repeat, here's our contact info and links. Please feel free to reach out with any further questions. We also have a full list of sources on the information that Brooke had spoke of today. So you will be able to see this in the presentation that is sent to you after the webinar. So I think with that, we're good. So thank you to all, and have a wonderful day.
Yes, thank you, everyone.